bile acid. And these sequestrants or absorption inhibitors, they are water insoluble, they are cationic polymer resins, and they are inert to digestive enzymes. And they have to be inert to digestive enzymes because digestive enzymes all around here. So you cannot be given an agent that's supposed to sequester the bile acid, and at the same time the enzymes are digesting them. That's what it means. You need to be able to leave them in a stable form. What are the examples? Cholesterol, Colesevelam. I make fun of Dr. Chelly. That's his first name. So Colesevelam and cholestyramine. They are useful in the reduction of elevated serum cholesterol, and they have similar efficacy, causing about 8 to 25% reduction in LDL at therapeutic concentrations. So because they bind to negatively charged bile acid, they are much more effective when the drug is present in the small intestine following meal. So when you find that certain drugs need to be given immediately after meal, it's because of things like this. That's when they are the most effective. Unlike the statins, they do not cause serious toxicity except for some bloating and upset stomach. So they are generally very safe. How do they act? When they bind to bile acids, they form a resting bile complex in the small intestine, and therefore they sequester bile. So that complex that is sequestered cannot be reabsorbed. So because it cannot be reabsorbed, it is excreted in the stool. So the bile acids are bound to it. The cholesterol is there. The resting complex bile cannot be reabsorbed, and the only way they can go out is in the stool. Okay. Now, naturally, 95% of bile acids are reabsorbed. Okay? Very yeah. There's that reabsorption. So, when there's decrease to the absorption of bile acid by the GI tract, it interrupts the enterohepatic circulation. And because there's now a depletion in the pool of bile acids, that now sets up like a feedback mechanism that increases the expression of this enzyme, cholesterol 7-hydroxylase, which then goes to increase hepatic bile acid synthesis from cholesterol. And that's what now causes the reduction in cholesterol concentration in the hepatocytes. I will not bore you with this part of the complex in terms of the feedback mechanism, and because it may be a little confusing for you. But just know that this sequestrant combined with with bile, and they are able to excrete the cholesterol that's bound to them in the urine. Yeah, that's all I will give you as far as the bile acids here is concerned. Except that I think there's another one that I want to make mention, is that you should remember that bile acids, as I mentioned before, are very important in the absorption of fat. So when the bile acid combined with the fat, and you have an agent that can prevent the absorption of that fat, that's why you have cholesterol, Colesevelam, functioning as bile acid sequestrants. The third category would be the inhibitors of cholesterol absorption. And the effects of these ones, they inhibit the absorption of dietary cholesterol in the small intestine. They also reduce the reabsorption of biliary cholesterol. also reduce the reabsorption of biliary cholesterol. So they make yet another blockade there, reabsorption of biliary cholesterol. So by so doing, there's a reduced delivery of cholesterol to the liver, therefore the hepatic cholesterol is less, and therefore there's increase in clearance of cholesterol from the body. The two available inhibitors are phytosterols, and they include plant sterols and stanols, and of course ezetimibe. This next slide talks about these plant sterols and stanols. They are natural substances. They are present naturally in plants, in fruits, nuts, vegetables, and grains. They are similar in structure to cholesterol and vary only in carbon side chains. The stanols on their own are saturated sterols with the methyl or ethyl group. And that's what Dr. Chaya to expatiate on. And the sterols are the steroids with an alcohol group. These phytosterols are similar in structure to cholesterol, and that helps them to reduce the absorption of cholesterol because they dummy the absorption process, thinking that the cholesterol is the one there. So there will not be a reduced cholesterol and less bile absorption from the gut. The phytosterols will reduce the absorption of both dietary and biliary cholesterol, and these ones are excreted out. The phytosterols themselves, of course, are virtually unabsorbed by the body, so it allows it to pass out in the urine. The ezetimibe is known to reduce intestinal cholesterol by about 20%. How does it act? It blocks the uptake of cholesterol. There's a protein at the brush border of the absorption site in the small intestine that is called the MAPC1-like 1 protein, MPC1L1. By binding to this channel, or this protein, allows the inhibition of cholesterol being absorbed from the intestine. And if cholesterol is not absorbed from the intestine, you have a reduction in dietary and biliary cholesterol that's going to the liver. With the reduction in the amount of cholesterol going to the liver, you have an increase in LDL receptor expression. And you know what increased LDL receptor expression does? It ends up reducing the amount of plasma concentration. So the outcome of this is a decrease in plasma LDL concentration and reduced hepatic cholesterol content. There's a combination that's common in the market now, is Vitorin. Vitorin is a combination of ezetimibe and simvastatin. Of course, you know, ezetimibe will reduce cholesterol absorption. And when a hepatic cholesterol is reduced, it can cause a compensatory increase in cholesterol biosynthesis in the liver. It's so funny that in hypercholesterolemia, when you are trying to reduce the level of one, then there's a feedback mechanism that now goes to increase the amount of another one. So this is a good example that when you just reduce cholesterol absorption, because the body the body knows it needs the cholesterol, there's a compensatory mechanism that starts stimulating cholesterol biosynthesis. What then happens is that when you now combine the ezetimibe that's reducing the cholesterol content with simvastatin that's inhibiting the synthesis, you tend to get a combined effect. And that's why Vitorin is a good combination of the two. So when you prevent that compensatory increase with statin, you take a good advantage of two mechanisms of action acting at the same time. So when you treat with Vitorin, It reduces total cholesterol, it reduces the LDL, bad cholesterol, and triglycerides, but it increases the HDL, the good cholesterol. Let me know if you are following me. Vitamin causes inhibition of endogenous synthesis of cholesterol. Is that correct?
True.
Is everybody clear about that?
What's the meaning of endogenous?
Huh?
What's the meaning of endogenous?
Endogenous. What's the meaning of exogenous? Exo, endo, exo, endo, exo, endo, exo, endo. Endogenous means the cholesterol within this body. That's right, within the body. Okay, so it does cause inhibition of endogenous synthesis of cholesterol by blocking HMG-CoA reductase. True or false? Adverse effect of ezetimibe is rhabdomyolysis. False. Which one is rhabdomyolysis? Statins. Okay, good. Let's go to the fourth class. These are the PCSK9 inhibitors. And these agents inhibit the degradation of LDL receptor. And by inhibiting the degradation of LDL receptor, they allow the LDL receptor to clear cholesterol from the system. There are two inhibitors that are approved for use. These two are alirocumab and evolucumab. They are injectable monoclonal antibodies. Anytime you see MAB, just know that refers to monoclonal antibody. Monoclonal antibody. Alirocumab and evolucumab are monoclonal antibodies that are presented in injectable forms. You can administer them every 2 or 4 weeks to the upper arm, to the stomach or upper thigh. It greatly reduces LDL particles. It has no side effects except very slight irritation at the site of injection. No side effects with the alirocumab and evolucumab. Answer me true or false. Alirocumab prevents degradation of LDL receptor. True or false? Alirocumab prevents degradation of LDL receptor. You know, it's a PCSK9 inhibitor.
Yeah, the action that you did. That's true. That's true. True. Remember that the enzyme inhibits. No, I thought that the PCSK9 was the enzyme.
It's true.
The enzyme is what degrades. I'm speaking true. It is true.
Like I say, you don't understand. You don't follow it.
Oh, prevents. Yes. So it prevents. Yes. It's true. It prevents.
Put it back.
It prevents that one from degrading.
Put it back.
It's true.
I don't want you to just
It's true.
Okay, so are we clear now? Alirocumab, okay. Let me go back here, because that's why I took time initially. I told you LDL receptor is normally degraded by this enzyme. Is LDL receptor good or bad? It is good. Right? It's good. So if it is good, we need to eliminate the bad guy. That's making the good guy look bad. It's like how many are parents here that how many are parents? They're parents. Okay, just few parents here. Okay. You're a parent too? Okay. Okay. All right. You're a parent here. I just want to make sure I use an analogy that will help you understand the thing. I'm a parent too. And I tell you what I did one time. My daughter was there dating someone I didn't like. Just pardon me, it's my daughter after all, it's not your daughter. So I have the right to do that. Okay, now, and I knew there's no hope in that relationship. But then she was head over heels. Okay, so I see myself as the LDL receptor. And I see that guy as the PSK9. Should I inhibit him or I should encourage him? So I was just acting like a Alirokuma at that time. So I was preventing the degradation of my daughter, of my parent. Okay. Does alirocumab inhibit cholesterol biosynthesis?
No.
Are we clear?
No.
Does it inhibit? It does not.
No.
What it does is it clears cholesterol. It does not inhibit the biosynthesis. If I change this to statin or simvastatin, does simvastatin prevent this?
No. Yes.
Dr.
Can we say
I
combo?
think that there's a word missing on the slide that threw us off. Because it's on the slide that we have, it says that it degrades LDL receptors.
Okay. Oh, it says it degrades.
Yeah, that's what it says on the back of on the PowerPoint.
Let me make sure.
See, but ours, the one that we have, it says it binds and degrades. So like the one that we have, it says it binds and degrades. It doesn't say binds and inhibits.
That refers to PCSK9, the enzyme. You get me? It is the enzyme, it's the PSK9 that degrades the LDL receptor. Oh, okay. Mine is wrong. So forget about mine. Forget about mine. Thank you, Kenny, for bringing that up. Okay. Your version is right, mine is wrong. Somebody has been getting into my file, huh? Okay, so thank you for pointing that out. So what you have is correct. It is the enzyme that binds and degrades the LDL receptor. So what the PSK9 inhibitors do is to inhibit it. So are we clear now? Are we clear?
Yes.
Okay. Okay, let me give you additional questions. Alirocumab is indicated for patients who are not stable for statin treatment. It's in your notes, but I didn't get to it. You didn't see that one. So I'm not going to read everything for you. Let me make sure. Was this statement? The inhibitors are approved particularly for treating heterozygous familial hypercholesterolemia and for patients who are not suitable for statin treatment. And what patients are not suitable for statin treatment? Pregnant mothers and nursing mothers. Very good. So that's the information I was trying to get there. Okay, and of course, I put one there that the side effect of evolocumab is myopathy. We know it's false, right? That's for statins. Okay. Now let's quickly go to the feet of the 7 groups. We have the fibrates, and these are the ones that are used for triglycerides and for HDL. If the patient has low HDL, the good one, then you go for fibrates. If the patient has high levels of triglycerides, you go for fibrates too. There are two of them. You have gemfibrozil or lopi, which is the second most useful anti-hyperlipidemic agent. And you have the fibrates, have the phenylfibrate, you have the bezafibrate, you have the cyclofibrate, all the fibrates. And what do these fibrates, how do they act? There is a receptor that they act on. We call it the peroxisome proliferator activated receptor alpha, PPA. PPA alpha. And this PPA alpha is expressed in several types of cells, including the hepatocytes. But more importantly, I don't want you to worry about this other information, is too hard for you. This receptor is linked to metabolism of lipids. So the more you are able to activate this receptor, the more you are able to carry out fat metabolism and break it down. As a matter of fact, they will act here, around here. So the PPA alpha, the fibrates, will be acting through the PPA receptor, and the PPA receptor will be breaking down the fats through a fatty acid oxidation mechanism. When you activate the PPA and you affect lipid metabolism, what it does mainly is to decrease the plasma triglycerides and increase the plasma HDL. How do they do this? One, they can increase lipoprotein lipase expression. When they increase lipoprotein lipase expression, the metabolism of triglycerides go up. It breaks down the triglycerides, and so you end up with a reduced level. If you remember apoprotein C3, they can decrease the expression of this because this apoprotein is an inhibitor of lipoprotein lipase itself. So you need to decrease it so you can increase lipoprotein expression and increase triglyceride metabolism. The other one that can happen is you increase the transcription of the ApoA1 and ApoA2. And it is this particular cofactor of apoproteins that actually increase HDL levels. So when you take this together, these three mechanisms, what do you end up with? You increase fatty acid uptake and fatty acid oxidation. And you also decrease plasma triglyceride levels. So that the combination of these three actions, when triglyceride metabolism goes up, you decrease the triglyceride levels in the body. When lipoproteins lipase activity goes up, you increase triglyceride metabolism, you decrease triglyceride levels. And when you increase the transcription of ApoA1 and ApoA2, you increase HDL levels. That's how fibrates increase HDL levels and decrease plasma triglycerides. You find out that we hardly talked about the LDL with this group of compounds. The sixth group would be the nicotinic acid or niacin. Nicotinic acid or niacin is a water-soluble vitamin which is known to decrease LDL cholesterol and triglycerides, but will also increase HDL. This is one thing you've noticed about nicotinic acid now, and it's one of my questions I may ask. This one affects all the three, it affects the three lipoproteins: LDL, triglycerides, and increased HDL at pharmacologic concentrations. For the others, at pharmacological concentrations, they have specific effects on one of those three, one or two of the three. This is one that affects all three at pharmacological concentrations. Nicotinic acid, being a vitamin, is a substrate in the synthesis of NAD and NADP. You should know that from biochemistry. They are very useful in the treatment of hyperlipidemia. For pharmacologic use, that's the dose. You will get more of that with the pharmacy practice. But then, when you give it a pharmacologic doses, you will notice that these increases are pretty similar. They are not too bad. That's why it's the only agent that has good activity on all three. So if you end up with a patient with a hypercholesterolemia, you're not too sure which particular one is high before then, this is one of the ones this is one you should consider giving, pending the time. You know, there's more of triglycerides and there's more of low density lipoprotein. Exact mechanism of nicotinic acid is not known, but these are some of the proposed mechanisms. It inhibits lipolysis by inhibiting lipase. So by so doing, there will be a reduced transport of fatty acids to the liver, and then hepatic triglyceride levels will go down. Then when you inhibit triglyceride synthesis, you also do that by esterification of fatty acids. That will reduce hepatic, very low density lipoproteins, and therefore will reduce LDL. And of course, it can increase LDL cholesterol by decreasing the clearance of ApoA1, decrease the clearance of HDL. Flushing and dyspepsia are the main side effects after you give it niacin. The last of the group that we'll treat today are the omega-3 fatty acids. There are two of them. There is eicosapentaenoic acid, EPA, and DHA, docosahexaenoic acids. Both of these are fish oils that are effective at reducing plasma triglycerides. How do these act? One of them is by activating that receptor PIPA, which works by increasing fatty acid oxidation in the liver. There are two that are available now. We have Luvasa. Luvasa contains DHA and EPA, and that's what I want you to pay attention to. Luvasa contains DHA and EPA. Vascepa, the other one, contains only EPA. Vascepa contains only EPA, and both of them are useful in reducing plasma triglycerides. Let's now do a couple of exercises now. So match this anti-hyperlipidemic agent with any of these transcription factors. So let me see what you are able to do. Lovastatin, which one will you put in there? Lovastatin, what will be the transcription factor? This is a tough question, I know.
Yes, because I'm like,
Okay.
so what do they say, the HMG coenzyme inhibitor, when it comes to that?
Very good. Okay. Very good. Okay. The HMG CoA reductase inhibitor will work with A. Okay. And because you know this is an HMG CoA reductase inhibitor, and this contains a statin too.
It contains both.
Yeah.
So these two go with it. All right. We sorted that out. What of Luvasa? Just finish with Luvasa. What group of agents is Luvasa?
You said omega.
Hmm?
You said omega. No?
Luvasa is just the very last slide I finished.
Yeah, and the DH something. Yeah, no.
DHA, EPA.
Yeah.
Okay.
So
And it's an omega-3 fatty
Yeah,
acid.
you said omega.
There's omega-3 fatty acid. Okay, flip to your previous slide. Flip to the very last slide. And tell me whether that's not true. Does it act on paper? Does it act on paper?
Yes.
Yes. I want to make sure you can read your.
He did the whole length. Yeah, he expanded. I just moved.
Yeah, some of you like activation, but then exam,
What you said?
exam, you're not going to
Yeah,
give you,
exactly. You're not gonna give us P card alpha.
it's not going to give you the okay, or at least to help. I'll put it there. I'll put the acronym there. Oh, yes.
Yeah.
So this is P bar alpha. Okay. What of basal fibrate? Basal fibrate.
Oh,
B is a fibrate, is correct. B. Eicosapentaenoic acid.
B. That's the same thing. EPA. Yeah,
That's EPA. Thank you very much. Okay. I just put this one so that don't be looking for EPA or DHA. You have to know exactly what it is.
It's easy to connect and move on.
Okay. So, all right. In exam, typically, I'll put the acronym because I know you like that. So, but in this case, I just want you to be able, what's EPA? You didn't mention anything like eicosapentaenoic acid. No, I did just in the previous slide.
Yeah.
Okay, so EPA does this. So, there's none here that uses the Nimapig one. This is the one that the NRC uses. Okay, so let's try this one now. Let's try lovastatin. Is it HDL, LDL, or triglyceride?
LDL.
And a little bit of.
Very good. LDL is the primary, let's say the appropriate primary target. Appropriate primary target. So lovastatin is LDL. Lovasa is what? It's omega-3, yes. And it's what?
Reduction of triglycerides.
All of them.
Such as this and that. And then preservative. Same thing as Lovasa. With this and this. They do not touch LDL. That's the sort of thing that I want you to know.
Oh, is it because it reduced triglycerides and if you reduce that and increase HDL?
Yeah,
That's okay.
that's their primary target. They reduce triglycerides and increase HDL. Let me give you an additional question since we have time. I'm giving you so many questions that I will not, you won't get more than this in your exam. And by the way, I think your exam, somebody asked me the other time, you have 8 questions.
First
In
one.
8 questions in this one, 8 questions for next week, and 12 questions in hypertension. Okay? 12, 8, 8. Making 30 questions.
No select on the apply, right?
You know, you will have to select everybody in the class. We cannot leave some out of the class now. So, do we want all the class to pass or just some?
Oh my God.
So, okay, select all students that want to pass. Okay.
C.
All right. Okay, so lovastatin. What's the side effect of lovastatin here? The C. What of cholesterol? Alirocumab?
None. No side effect. So your side effect,
Except for the
injection site.
Only
at the injection site, yeah. So D.
No, very good. So
And then A is for.
that one.
A is for, the license does function.
All right, thank you very much. I'll see you next week.